talk about Module W, end-of-life care. We're going to describe the nurse aide's role in end-of-life care, describe cultural differences in dealing with end-of-life, and examine your own feelings, our own feelings about the end of life. So, of course, end-of-life care is the support and care provided during the time surrounding death. This may last weeks, days, months, or years, realistically. Some people are given terminal illnesses, and they're told they've got months to live, and they can live much longer. But in reality, usually this happens the last days, weeks, and months of someone's life. Let's talk about a couple of terms. Terminal illness is an illness or injury that a person will not likely recover from. Terminal illnesses always end in death. Sometimes it's, somebody has been in treatment for a disease process. Let's use cancer. They've been in treatment for a long time, and then all of a sudden they're diagnosed terminal. Usually that means that the doctors have exhausted all possible treatments, and that curing them of cancer is just not working. It's just not going to happen. So doctors at this point have decided that there's nothing else that we can do to try to cure you, and that in the end the disease process is going to end up taking your life. Sometimes people are diagnosed and they are already terminal. Sometimes you can ignore a disease process, or some diseases don't show themselves until the very, very end. And then when you're diagnosed, there's no ability to cure whatever the process is. Dying is the near end of life or near cessation of bodily functions. Death is the actual end of life and cessation of bodily functions. That's when everything stops. Of course, postmortem care is the care of the body after death. So it's what we do for the body to prep it for the morgue or the nursing home. An obituary is the description typically placed in the local newspaper of a resident's life written upon the death of that resident. These can be short, little brief statements of when the services will be held, or they can be longer. Usually they talk about who the person is, who is still living, survived by children, spouses, grandchildren, things like that. You buy obituaries, so if you see sometimes in the paper they have these really half-page obituaries or really long descriptions of someone's life, somebody paid to have that put in, and you can make an obituary whatever you want it to be. Just be aware that sometimes that can be very expensive. But everybody has an obituary placed in the paper, because the paper allows for 3 lines or whatever for free, but then the bigger ones you did pay for. Let's talk a little bit about death. This is the natural conclusion of life. We aren't getting out of here alive. We will all die of something someday. We don't know when. It may be a sudden death and unexpected, or somebody may have been sick for a long time, and we knew that they were going to die, and we were prepared for it, even though you're never really prepared. The resident's response to death is based on personal, cultural, and religious beliefs and experiences. It's very, very unique to each person. It can affect their emotions and behavior. And of course, the nurse aide's feeling about death can affect the care given. Obviously, it's often the caregiver closest to the resident is the nurse aide, so you will get to know them. They will be somebody that you miss when they pass. And of course, it's important for the nurse aide to understand the dying process and how to react and approach the resident with care, kindness, and respect. We want to make sure that we're giving the resident all the care that they need, even though we know that they are dying or close to dying. Grief is the deep distress and sorrow we feel over a loss. It can be the loss of a person who actually passed. It can be the loss of a relationship. You can feel grief over the loss of anything. It doesn't necessarily have to be death, but we're going to put it in terms of death right now. The dying resident and the family may pass through the 5 stages of grief, which was developed by Dr. Elizabeth Kubler-Ross. And when she developed this, she did a really good job, because it does really make a lot of sense when you think about it. Of course, each person experiences the stages of death differently. They enter the stages of grief at different points. We'll talk about each one of those. And they may not even pass through the stages if death is fast or unexpected. So it's possible that the resident doesn't really get to go through the stages of grief, even though you may see the stages of grief happen in their family once the resident has passed. The nurse aide's role is to understand these stages and do not take the anger personally. Don't take what's thrown at you in response to grief personally, because it's not really about you. Listen and be ready to assist the resident however they may need to be assisted. Let's talk about stage 1, denial. This begins usually when people are told of impending death. So you have been informed that you have a terminal illness, and now no, I feel fine. I'm not sick. I'm not going to die. No, I just had a little cold. There's no way I've got cancer. There's no way that I've got terminal lung disease. They refuse to accept the diagnosis or even discuss the situation. They may want a second opinion because that guy is a quack. The lab made a mistake. The pathologist got somebody else mixed up with me. This isn't me. This is the no, not me stage. Okay. They act like, everything's fine. They don't want to talk about it. Stage 2 is the anger stage. Usually this is where you'll see these expressions of rage and resentment. It is a normal, healthy reaction. They may lash out at the smallest things. It may be you dropped a pen on the floor and all of a sudden they're yelling because, making all kinds of racket, the smallest things. This is when the resident or the person starts to face the possibility of upcoming death, and they're mad about it. Like they may have lived a great life, they ran marathons, they never smoked, they never drank, and yet now they're dying of this horrible disease when their neighbor next door eats hot dogs, potato chips, smokes and drinks all day long, and why aren't they sick? So they have real resentment. Unfortunately, they may take that out on you, and you, as the nurse aide, the person taking care of them, and you don't ever take this personally, because you didn't give them whatever they're dying of, I promise. But they will take it out on you because you're available and you seem like a safe target, and that doesn't make it right, which is why we don't take it personally. If the resident's angry, you can feel free. I'm sorry you're having a bad day. Let me remove myself so, I'll stop upsetting you. Or if they just feel they need to yell at somebody and get it off of their chest, and you're willing to stand there and just be yelled at about stuff that you have no control over, I'm fine with that. I have no problem with that. You feel free to tell me what you need me to hear, because I know I'm not the cause of this. And it's easy for me to detach from whatever they're saying, to be able to understand that they're just really expressing their fears and expressing their feelings about dying. This is known as the why me stage, and you'll hear that yelled a lot. The third stage, known as bargaining, this is when they're trying to arrange for more time to take care of unfinished business or to just see the end of something. This is where bargains with doctors or God is made. Well, if I do this, then I can just give me a little bit more time. I promise I'll do this if you'll give me that. So this is where they're trying to get more time. If I could only see my grandchildren grow up, what do I need to do in order to, see my daughter get married, or, see the birth of my first grandchild, whatever it is. They're usually bargaining for something. This stage is usually very private. They don't really say these things out loud because they're not bargaining with you specifically. They're bargaining with God usually. They pray a lot. They may be very silent. This is the yes, me, but stage. Yeah, okay, so I know I'm dying, but I don't want to die just yet. I want a little bit more. And that is that's usually done very, very silently through prayer. The fourth stage is depression. It begins the process of mourning. If they finally have come to the point to where they know there is death is coming. They cry a lot. They withdraw from others. They don't really want to spend time or be around other people. They may become weaker with worsening symptoms, or worsening signs of things. They lack the strength to do simple things. They may need additional assistance with physical care and emotional support. This is the yes, me stage. Okay, so I know I'm dying, but I'm not happy about it. I don't feel good about it. The nurse aide needs to demonstrate a lot of understanding and willingness to listen at this stage. If they want to talk about it, it's important to listen, because they may tell you things that they really need to get off their chest. They may need to tell you what they can't tell their family. So it's important to really listen during this stage of depression or stage of grief. The fifth stage is acceptance. This is where the resident has worked through all the feelings and they understand that death is coming and they accept that it's coming. They're calm, they're at peace with their decisions, they accept that death is there. Some people may or may not make it to this stage. Some people never make it to this stage of grief. This is where people start to get their affairs in order. They start giving stuff away. They start planning their funerals. They start, saying all the things that they want to make sure get said before they die. They make plans for who's going to take care of, their pets, or who's going to get this or who's going to get that. And of course, the important thing to remember is just because they reach this stage of grief doesn't mean that death is imminent. It doesn't mean they're going to die tomorrow or next week. Some people accept it from the start, like they're given a terminal illness diagnosis, and they're like, okay, I kind of knew this was coming. All right, they may start here at this accepted stage. That doesn't mean that they won't go backwards. You can move through the stages of grief in a lot of, it's a spectrum. You move up and down that scale. So you may get to the acceptance phase and move to the next day and you're back at the denial stage. Like, you can jump around in the stages of grief and move forward and backwards through the process as you come to understand that death is going to happen, and as your families accept death can happen. So it's not static and it's not one direction. You can go back and forth. Advanced care planning are the choices about medical care the individual would want to receive if he or she were suddenly unable or could not make those decisions for themselves. We call these advanced directives. We call these living wills. This is really what you want to let everybody know how you want it done should you not be able to make this decision for yourself. So it can go all the way to, I don't want to have CPR done. I want to be a do not resuscitate. I don't want to, it's okay to do CPR, but don't intubate me. If I'm not able to eat, I don't want a feeding tube put in, but it's okay to give me IV fluids, or I don't want IV fluids. Like, you can be very specific in your advanced care planning if, based on the outcome of the care being provided, will prolong your quality of life. You can choose whatever you want. And it can be very specific. When we talk about advanced directives, this is one of the documents that we use in order to convey what we want. The Patient Self-Determination Act allowed us to gave us the ability to accept or refuse treatment as we wish. It gives us the right to choose what we want to do. It also allows for residents to name a person to make these decisions for them. And we'll talk about medical power of attorneys here or durable power of attorneys in just a second. Advanced directives are legal documents that allow people to decide what kind of medical care to have in the event they cannot make those decisions for themselves. They're required if you're in a long-term care facility. Every long-term care resident has an advanced directive that lets them know what they want and what they don't want. The advanced directive can say, I want everything done. I want CPR, I want to be intubated, if I can't eat, I want you to put in a feeding tube. They want everything done. Or they can say they don't want anything done. So you can pick and choose along that entire scale. Durable power of attorney, a living will, is the document that outlines the medical care a person wants or doesn't want in case the person cannot make that decision. And of course, it must be written while you're completely mentally competent. Or it can be written by the resident's legal representative. So you have to be competent to make these choices, and you can change these choices based on the day if you wish. You may have been admitted and said you wanted to be a full code. Now you've been there a while and you decided you don't want that. You want something different. You can make changes. It doesn't have to stay the same. Your durable healthcare power of attorney is a document signed and dated, witnessed. It is legal that appoints someone to make these healthcare decisions for a person in the event he or she cannot do so. So you are going to name in your durable healthcare power of attorney a medical power of attorney, someone who can make these decisions for you. These are different than living wills, or excuse me, estate wills, which says who you want your house to go to, who you want your jewelry to go to. That is a different kind of will. A living will talks about what you want to do, and a healthcare power of attorney gives somebody specific permission to make decisions for you should you not be able to make those decisions for yourself regarding your health care. They don't take care of your finances. It has nothing to do with that. This is simply surrounding health care. So let's talk about the DNR. That's a medical order which instructs medical personnel to not perform CPR if a person is no longer has a pulse or is breathing. Okay, if a person has a DNR, we must honor that DNR and not initiate CPR. It allows the person to die peacefully, and we don't go in there and do extraordinary measures such as chest compressions and intubations and things like that. So we have to honor the DNR. The healthcare team usually works with the resident to make sure that they understand prior to making this decision what it means. We want to make sure that they're making an informed decision. And these are typically written for people who have terminal illnesses. They know that even if we do bring them back, it's not going to be for very long, because the disease that's killing them is still trying to kill them. A person who almost certainly could not be saved if CPR was initiated. Sometimes you have somebody who is 97 years old who doesn't have any disease processes other than the fact that they're old, and their body is just kind of shutting down on them because, that's what the body does. So somebody who's 97, they may not be a DNR. You cannot make that assumption. But just because usually when they get older, DNRs are written for older adults because they would not necessarily survive even if we did initiate CPR. Physician orders for life-sustaining treatments. These are doctor's orders stating what treatments are to be used when a person is sick. They include medical measures the resident wants to receive and not those to be withheld. Like I was talking about, tubes or IV fluids. They're based on conversations between the resident and the doctors that follow the resident's beliefs, goals, what the diagnosis is, what the prognosis of the diagnosis is, and what all the options are. So, of course, what are the benefits and the detriments of each type of option? And then these decisions become part of the medical order. So you have long conversations with the resident and let them know exactly what we're talking about. Is it a feeding tube? Are they IV fluids? Are they antibiotics? What kinds of things do you want us to do, and what kinds of things do you want us to withhold? That way we know exactly what to do should you not be able to make these decisions for yourself, and then somebody else isn't making this decision for you. As long as they are competent, the resident is allowed to do this for themselves. These are usually done in long-term care facilities. You won't see these very often in the acute care setting, because the acute care setting is designed to fix a problem. The resident goes in for antibiotics for an infection. We are going to give them antibiotics to treat that, or why did the resident go to the hospital? So you will see physicians' orders for life-sustaining treatment usually in long-term care settings. Or hospice care. Let's talk about hospice care. Hospice care is a healthcare agency or program for people who are dying. Usually you have to be diagnosed with a terminal illness in order to receive hospice care. The purpose is to improve the quality of life for the person who is dying, but it is not designed to cure them or get rid of a disease. They provide comfort measures and pain management. This does not mean that we don't, we give pain medicine. This doesn't mean we only give pain medicine. If the resident is in hospice care, they may be getting chemo to help control the symptoms or the pain caused by the tumors, or they may have an infection, so we're going to treat the infection. They may be in there for cancer, but that doesn't mean that we have to let them, have pneumonia. We're going to give them antibiotics to treat their pneumonia. We want to preserve dignity, respect, and choice for the resident. And we also offer empathy and support for the family and the resident as well. When you are working in hospice care, you don't have just one patient. You have the patient and their family. So you are actually caring for a group of people surrounding a person who is dying, and not just a person. And it's important to keep that in mind. With palliative care, in hospice care, the goals are to keep the resident comfortable and to maintain their dignity. Palliative care is a type of care given to the resident who are dying, which of course focuses on relieving pain, controlling symptoms, and minimizing side effects and complications of treatment or their disease process. The nurse aide's role in palliative care is to be a good listener, obviously respect privacy and independence of the individual. You're always going to provide individualized care and be aware of your own feelings and the stress that you may be feeling so you don't let that inadvertently fall on the resident. And of course, the nurse aide must take care of yourself in order to provide palliative care to others. So you have to make sure that you are maintaining a good mental health stress level. You don't want to get too far in. You don't want to let that grief overwhelm you or the care of taking care of somebody take over what you're doing, because then you won't be able to provide sufficient care to somebody else. So of course, end-of-life care usually happens in a hospital or long-term care facility. While people say they want to die at home, most deaths don't happen in home. They usually happen in a facility. And of course, the nurse aide's feeling about death can affect the care you're given, which is why we put that self-assessment up, so you can kind of get an idea about where you stand on death. If you've dealt with death in the past, you probably have a different point of view than somebody who has never dealt with death. So, everybody has a different scale for that. When providing end-of-life care, it's important to be kind and respectful and approach the resident and their family with empathy. And be there for them. Sometimes it's just a quiet moment. Sometimes it's just holding a hand or giving a hug. We don't really have an answer, but we can provide support in quiet ways. And of course, the nurse aide must recognize their own feelings and deal with them. We've talked about this. Many factors influence the residents or the nurse aide's attitude. Again, we've talked about that. First encounters with death can be very frightening. So somebody who has never dealt with death may not handle their first resident who passes away very well. They may be very emotional. They may, actually be overwhelmed by the experience. So we want to encourage you to use your coworkers as support for dealing with these issues. Aides who have been doing the job a long time have dealt with this. They're more familiar with it, and they may have the ability to, they can help you deal with the feelings that come with the death of a resident. So of course, when you're taking care of somebody who is dying, we want to keep the room well lit and well ventilated. We're not shuttering it down, keeping it dark. There's no reason for it to be dark or morbid. We want to keep it well ventilated, so we don't want to shut them down, keep them locked up in a cave or a hole. We want to make sure the drapes are open, that they're getting sunlight. We can play the TV, play the radio, make sure the resident is enjoying whatever the stimulation that is going on in the room. If there are visitors there, have conversations, enjoy and encourage the conversations. So we want to make sure that the room, we act as normal as we possibly can, but we don't want to act like nothing's going on. So we talk about the physical needs of the resident who is dying. Positioning, we want to place them in a position of comfort, okay, however they are most comfortable. We want to make sure that they can breathe well, and we're trying to avoid pain as much as possible. We want to maintain body alignment and change the resident's position frequently to avoid pressures. We don't need to add more pain to their already painful process. So we want to make sure that we are positioning them, repositioning them, making sure that we're taking care of their needs, doing good skin care, making sure that they're clean, offering bathing and grooming frequently to promote self-esteem. Just because they're dying doesn't mean they don't want to look nice. We want to make sure that we provide back rubs that can help with comfort, can help with circulation. We want to make sure their mouth and nose stay clean. If there are sores, we want to make sure that we are taking care of those as they're supposed to be taken care of. If there's bleeding, we want to follow standard precautions. Always make sure you have on gloves when dealing with these issues. We want to provide oral care frequently. Maybe as often as every 2 hours when you reposition them, you're going to want to provide oral care. This may simply be wiping their mouth and putting on a moisturizer to keep their lips from drying out and cracking. It may be full mouth care. You may be doing it with swabs, or if they're alert and oriented and can help and you can use a toothbrush, then that's what you would do. You want to offer fluids if they're able to drink. You want to make sure that that they're in good positioning for that, so they don't choke. We want to make sure that they have what they need. For nutrition, we want them to eat whatever they want to eat. At this point, balanced nutrition is not required. We're not really worried about did they eat their vegetables. If a milkshake makes them feel better and they'll take in a few bites of it, then let's give them a milkshake. Right now, it's about getting calories in them and not necessarily about making sure that they have balanced nutritional meals. We offer these in small, frequent sessions because they may not be able to eat a full meal. They may be able to take 2 or 3 bites now, and in 30 minutes or an hour, take 2 or 3 bites more. So again, we want to make sure that we are offering them things to eat frequently. And of course, with elimination, we want to keep the residents' skin and linen dry. We want to make sure that their bed is always as wrinkle-free and clean as we can make it. We want to provide peri-care as often as possible. At this point, usually the resident, if they weren't incontinent before, they may become incontinent now, so we want to make sure we take care of that. Providing emotional support can be even more difficult than providing for the physical needs. We want to identify incidents that affect the resident's mood and note behavior changes, report those to the nurse because they may need to be added to the care plan. Approach the resident and the dying process with dignity. Again, we want to act like we want to keep the environment as normal as possible, but we don't want to act like nothing is happening. It's kind of a balance, right? Respect the residents' ideas of death and their spiritual beliefs. Again, they may have a different belief than you, so what they believe is their belief, and we don't push our beliefs on them. We use touch where appropriate. Like I said, a quiet moment of just holding their hand may be all they need. Maybe rub their shoulder, whatever is appropriate. Listen to the family and the resident. Make sure that you're hearing what they have to say. Communicate with them, even if it's non-responsive. Even if the resident is non-responsive, you're going to still talk to them. We believe hearing is the last sense that goes, so we want to talk to them, explain to them what's going on, tell them what we're doing. Talk to them while you're caring for them. Give them that stimulation. Of course, be aware that the sensitivity to what is being said may cause a resident to be more emotional. So you want to be guided by the resident's attitude. You want to give the family and the resident privacy to interact, but you don't want to isolate them either. Like I said, you want to give them privacy, but you're not going to leave them alone for long periods of time. And you definitely don't want to shut the door, make them feel like they have to stay in the room, that nobody wants to know what's going on. So you want to provide for privacy, but not make them feel isolated. Spend time with the resident when you can, even if you're not providing care. If they're angry, don't take that personally. Be supportive and respect the residents' and family's spiritual beliefs. Again, we can't say that enough. And encourage family members to participate in the care as much as possible. They may not want to, but we want to give them the opportunity to. So we ask, do you want to help? Of course, culture and religion provide a framework for which personal experience with death take on meaning. Again, we all view it very differently. Things like religion and age influence an individual's belief that may differ from the nurse aide's beliefs. So we do not tell them or push our beliefs on them. We want to make sure that the team provides for respectful care to the resident always. So even though they may have a different cultural or religious belief, we meet them at their level. We become a blank sheet. What we believe doesn't matter. We meet them at their level and provide for the needs that they need us to provide for, even if we don't necessarily agree with it. If you don't understand what their practices are, it's always good to ask. That is the best source of information, is to ask the family or the resident directly. So when you pass, or what kinds of things should I know to make sure I care for you in the manner in which you want me to care for you? I had a resident's family or a patient's family who really, they were very concerned with their family member dying in the hospital because the windows didn't open and their spirit couldn't get out of the hospital. They were afraid they'd be trapped in the hospital. So we worked with figuring out how to make it happen. We moved the resident down to a room at the end of the hall near the fire escape. We got permission from security to, when he died, we'd be able to hold the doors open so the family members could know that the spirit had a way to get out. Their family member's spirit had a way to get out. I asked them what they needed, and I was able to provide, and that made me feel good. So ask. Don't be afraid to ask. It's the best source of information. The best way to know what they want is to ask them specifically and directly. Some of the questions you may want to ask: who is allowed to provide personal care after your death? Sometimes, some religions or cultures believe that same gender have to take care of same gender. So a female must take care of a female patient and male must take care of male, or vice versa. Sometimes it has to be a family member. It can't be a stranger. So do family members have to do it? Are there specific post-mortem things that you want us to know? So don't be afraid to ask those questions. Some cultures believe dying at home is preferable, while others fear dying at home. Again, this is a cultural variation, depending on what you feel you may need. Some cultures, such as Chinese cultures, believe that herbal preparations can help with the passing, and they may be only given once. The Japanese culture believes the number 4 means death, so you may have to change a room that they're in, or when you're doing something, to avoid the number 4, or doing things 4 times a day. The Vietnamese culture believes in reincarnation, so somebody may not react to the death of a family member the way we think they might, because they believe that they've now served their purpose in this life and have moved on. They may view the death of a 3-year-old, which we would see as tragic, as the resolution of this life, and they've already moved on to whatever they're supposed to do. So, they may not view that death as tragic because they believe their loved one has, already moved to the next level. And of course, the Hindu culture and other cultures don't believe in blood transfusions. They may not believe in certain types of care, autopsies, or organ donation. This is why it's important to ask. Staff and family may not be prepared for the actual moment of death, even though they knew it was coming. It can be prolonged, but we may not be ready. You may be shocked or surprised. I didn't realize he was going to go today. He had a good day yesterday. And there is some truth in that too, that there's like this burst of energy right before death. So somebody may look like they're getting better, and then they pass away, what we would consider suddenly or unexpectedly. Always recognize the variety of feelings and responses that may be displayed: guilt, anger, sadness, depression, avoidance, denial, acceptance, and relief. There may be relief with death. Maybe because the suffering is gone. Maybe because their family member has had Alzheimer's disease and they have just watched them change and suffer for so long that they may be relieved now that they've passed. But they may also feel guilt about that. So you have to understand that sometimes there is a varying number of emotions going on, and those emotions may be fighting against each other, and the family members may not understand why that is. Family members, especially if someone who's had Alzheimer's disease, they may not react because the person they knew died a long time ago. Alzheimer's robbed them of their loved one a long time ago, and they have just been in this prolonged process of grief, waiting for the body to die. So their feelings may be completely different. Their reactions may be very different than what you would expect. So it's important to listen empathetically. You don't want to give them advice, but you do want to let them know you hear what they're saying and you understand. So we want to demonstrate a caring, interested attitude while listening, and observe for changes in the other residents, because these residents are around people who die more often than most of us are. And the death of a resident could be the death of a friend of theirs. So we want to make sure that we're watching the other residents as well, and make sure that we are reporting that information and reporting it appropriately. So how do we know death is coming? Family members will ask for this. Well, when will I know? It's hard to tell, but some things that we see, psychological and physical withdrawal. They're no longer reacting or responding to you. There's a decreased level of alertness with increased periods of sleeping, so they're just asleep more often. The body temperature may rise. The body may feel cool or look pale. They may be perspiring a lot. The circulatory system starts to fail. The pulse may be fast or slow, maybe weak and irregular. The blood pressure may drop. Extremities may become cold and pale. Mottling may occur. That's that bluish kind of color discoloration on the skin. The respiratory system will fail. You may get irregular, rapid and shallow, or slow and heavy breathing. Shane-Stokes breathing, something that you'll see in somebody who is dying. This is when the resident will take several shallow breaths, followed by periods of no breathing at all for 5, 30, or even 60 seconds, and then they'll start breathing again. This does not cause any distress to the resident, but it will cause distress to the family when they see it happen, because every time they stop breathing, they think, is this it? So it will cause distress to the family, even though it is not just uncomfortable to the resident. There may be noisy respirations. Some people call this a death rattle. It's when mucus collects in the airway and just rattles around as the resident breathes. And of course, then there's apnea, when there is no respirations at all. The digestive system will slow down. The abdomen may distend. There may be fecal incontinence due to the relaxed muscles of the anal sphincters. There may be nausea and vomiting. The urinary system, the kidneys start to shut down. The urine, the amount goes down significantly. Urine gets darker due to the decreased blood supply of the kidneys. And of course, they may become incontinent at this point because of relaxed muscles in those sphincters as well. Muscle tone usually starts to decrease from the feet and legs moving up the body, and eventually the mouth muscles will relax and the jaw will sag and the body will become limp. Sensory perception begins to decline, usually blurred or failing vision. The person may stare and not respond. There may be no blinking, so their eyes just may stay open. The sense of touch is diminished. Of course, we talked about hearing being the last sense that we believe goes, but so we just continue to talk to them and tell them what we're doing. And of course, the sensation of feeling pain decreases with the loss of consciousness. So when they're no longer waking up, they stop really feeling or responding to pain. Or they may feel pain, they just stop responding to it. Death, of course, is the lack of a heartbeat, no pulse, no heartbeat, no respirations, there is no blood pressure. The eyelids will remain open and the pupils will become dilated and fixed, which means they're really, really wide. You'll see more pupil than you do color in the eye. There's no response when the resident is talked to or touched. The mouth may remain open, of course, because the jaw has slacked. There may be bowel and bladder incontinence. And of course, you're going to want to notify the nurse immediately so she can come in and do whatever needs to happen, especially since it is a DNR. She's going to want to come in and follow the process for pronouncing the person, giving a time of death, and notifying whoever needs to be notified if family's not in the room. If they are a full code, at this point we would initiate CPR, regardless of what we feel like the outcome would be. You can't not initiate CPR if the person is the full code. Once the person has passed away, death has been pronounced, we then start providing postmortem care, which of course is the care we give to the body after death. You consult with a nurse to find out what she wants done. If there are dentures, you're going to make sure that those are, do we want them put in the mouth or do we want them left out to be placed by the funeral home at a later time? If rings are removed, make sure you secure them per the facility policy. The family may want to view the body, so we're going to prepare the body for that. Understand that within 2 to 4 hours after death, rigor mortis starts to set in. That's when the body starts to get stiff. Rigor mortis will leave the body usually within about 24 hours after death, so it sets in pretty quickly and it goes away pretty quickly. As you're doing postmortem care and you're turning your person from side to side to provide this care, air may escape from the lungs. It doesn't mean the person's breathing again. This can be very frightening. It can be very startling when it happens. It may come out and, it may, the body may expel air. So there may be, pass gas. They may, so you may hear different sounds from the body. It's perfectly normal. You definitely want to wash the body and comb the hair, put on a gown and cover the perineal area with a pad because, of course, body fluids will still continue to leak from the body now that everything has relaxed. We place the body supine, which, of course, is face up, with the legs straight and the arms folded across the abdomen with one pillow under the head. If the family's going to view the person, we pull the covers up to the shoulders. We don't ever pull it all the way over the head because that is very, very disturbing to the family to see. So we prepare the patient like they're sleeping, and we pull the covers up to their shoulders and let the family then come in and visit. We always want to show the family members a private place to sit if they don't want to participate in care. If they want to participate in postmortem care, we always let them. They may feel that this is the last respect they can give to their family member, so we want to make sure that they have the right So we ask, do you want to assist? We don't force. If they don't want to, they don't have to. We show them where they can sit, have a private place to be with family members. Inquire if there's anyone that needs to be called. We provide for water or a beverage for them to sip. If family members would like to visit with the deceased, we want to provide for privacy and close the door quietly. If there's a roommate in the room, we usually want to have the roommate be somewhere else because they may not want to be a part of that. And of course, nurse aides respond differently to the death of a resident, so it's important to understand how your feelings are surrounding death so you can appropriately respond. And of course, you never know what to say, right? The family members are going to want to look at you for guidance and, what do you say? The key is just be sincere. Don't say something about a resident that you don't believe. You may have taken care of crotchety old Mr. Smith forever, and he was mean to you, and you're not sad that he's dead. Don't say that. Don't say, well, he was a great guy, and I appreciated taking care of him, because they probably know he was a crotchety old man too. But it's okay to say, I'm sorry for your loss. That is perfectly acceptable. I'm so sorry. If you really, really enjoyed taking care of Mrs. Smith or Mr. Brown or Mr. Smith, let them know that. He was so funny. I enjoyed his stories. He always had a good joke, whatever. It's important to let the family members know if there's something fun or positive that you can share. But always make sure whatever you say to the family members is true and sincere. Don't try to give them, platitudes like, oh, well, he's in a better place, because they don't necessarily want to hear that. Share with them the stories that you have to share, because they might enjoy that too. But that is Module W, and I will go back and relecture Module G.